and prosthetics are two distinct but related fields. Both are crucial for physical therapists, and they represent powerful tools in our rehabilitation arsenal. Orthotics are external devices. They're used to support, align, prevent, and correct deformities. They can also improve the function of movable parts of the body. Think of a brace for a sprained ankle, or a custom insole for your shoe. These devices don't replace a body part. They assist what's already there. They provide stability where it's lacking or help control excessive or painful motion. Prosthetics are different. They replace a missing part to restore function and daily activity. Orthotic devices are categorized by the body part they support. Let's start from the ground up with lower limb orthoses. The most common are foot orthoses, or AFOs, custom insoles to correct mechanics. They help conditions like plantar fasciitis or flat feet. Ankle-foot orthoses encompass the ankle and foot, rigid or hinged for control. They're often used to control ankle position, especially with drop foot. KAFOs extend from foot past knee, adding stability for standing and walking. They're used with weakness or instability at both ankle and knee. KAFOs add a pelvic section to control the hip, used in significant paralysis. Spinal orthoses support or immobilize the spine, from soft collar to TLSO and halo. Scoliosis braces like the Boston brace help prevent curve progression. Upper limb orthoses range from simple wrist splints to dynamic splints that assist motion. Prosthetic devices are classified by amputation level. Transtibial prostheses include a well-fitted socket, a pylon, and a prosthetic foot. The socket must fit perfectly. Poor fit causes pain and skin breakdown. Feet range from simple solid to advanced energy-storing designs. Transfemoral prostheses add a knee unit, making the system more complex. Designs span manual lock hinges to microprocessor-controlled knees for natural gait. Upper limb levels include transradial and transhumeral. Prostheses can be passive, body-powered, or myoelectric. Body-powered uses harness and cables, offering durability and feedback. Myoelectric systems detect muscle signals to drive motors for hand and wrist. They offer more natural control and strong grip, but are heavier and require training. PTs play a key role in teaching control. Patience and practice are essential. To work effectively with O&P, build strong anatomy, biomechanics, and kinesiology foundations. Understand normal movement to identify abnormal patterns and device needs. Foot and ankle biomechanics guide AFO selection. Assess skin integrity, muscle strength, range of motion, and sensation. For prostheses, evaluate residual limb shape, length, and skin condition. Thorough assessment ensures the device is appropriate, and the patient is a good candidate. You are part of a rehabilitation team. Collaboration is key. Communicate assessment findings clearly. Report fit and function issues immediately, like persistent redness from an AFO. Effective teamwork yields devices that are safe, comfortable, and goal-driven. Be an excellent teacher, donning and doffing, skin and device care, functional use. Train Gait for new prosthetic legs and task practice for hand splints. Gait analysis is the systematic study of human walking. Identify deviations from normal patterns. With an AFO, check if it prevents foot drop and ensures ground clearance. Observe stance stability and ankle support. For transtibial gait, assess step length and timing symmetry. Less time on the prosthetic limb can reflect pain, instability, or lack of confidence. Watch for excessive knee stiffness, often compensation for weak hip muscles or fear of buckling. In transfemoral gait, monitor swing control and avoid terminal impact. During stance, the prosthetic knee should feel stable and inspire confidence. Observe trunk and pelvic motion. Length issues can drive compensations. Listen for squeaks or clicks. Combine objective observation with patient feedback. A comprehensive analysis guides adjustments and therapy changes. Skill grows with practice. When starting with O&P, keep it simple and focus on fundamentals. First steps: check fit and check the skin. Teach skin inspection. Persistent redness signals excessive pressure. Emphasize skin care from day one. Build confidence gradually. Start in parallel bars before progressing. Progress to a walker, then crutches, then no assistive device. The device is a tool. Prioritize the patient's functional goals. Practice meaningful activities that show real-world benefits. Be an advocate and lifelong learner. Courses, journals, O&P collaborations. Advocate for modifications when needed. Your PT expertise is vital. Small, achievable goals reduce anxiety and build momentum. guide patients safely and effectively from first steps to independence. We journeyed through the foundations of orthotics and prosthetics. Orthotics support the body. Prosthetics replace a missing part. We explored device types, from foot orthoses to complex myoelectric arms. Understanding variety supports informed clinical decisions and collaboration. Essential skills include biomechanics, thorough assessment, clear communication, and effective teaching. Great therapists blend objective analysis with patient feedback. Prioritize skin, progress gradually, focus on personal goals, and never stop learning. You'll witness profound transformations. Embrace this challenging and rewarding specialty. It's the intersection of human movement, engineering, and compassionate care. You help restore function, hope, and independence. With this knowledge, you're ready to lead and help patients truly thrive.